So Dr. Athanasakis is a local surgeon here from Irakli. He was born and works here many years and works in the University Hospital of Iraklion. And as he proposed to me to say in his email when I asked him to how I should introduce him, he said that he's the most safest surgeon and in Southern Europe, and also he's the most handsome surgeon. And
thank you for your good
words. He's going to talk about the elderly surgery in the elderly people, and I'm afraid that he's become accustomed to this talk, and he's become an expert in the elderly patient surgery, and it will be really nice to hear him talk about it.
Well, many thanks for your kind introduction. Okay. So, I will try to present you the problem with elderly patients having colorectal cancer and need operating for this. And having in mind that life expectancy at the age of 60 is about 20 years and increasing, it is estimated that until 2050, about 1.5 billion people in this planet will be over the age of 65. So, as you can see, there will be a significant problem for colorectal cancer in these patients, because there is increased incidence of colorectal cancer in this group of patients, and increased incidence of colorectal cancer-related mortality in these patients. And of course, these patients have significant comorbidities, especially impairment of immune system, that render them incapable of fighting any septic complications after surgery. Fortunately, the elderly patients at presentations have lower in end stage and less common M1 disease. However, they have higher T stage. They have a locally advanced cancer mainly. And in terms of cancer itself, they are good. Several of these patients are good candidates for surgery, provided that they are fit for surgery. So nowadays we have several scores that we can use, several parameters we can evaluate for evaluating these people and predict the mortality and morbidity after this surgery. The most common used, at least in our clinic, is CR-POSUM score. We now know that there are several factors that can influence colorectal cancer surgery, colorectal cancer patients' outcome after operation. For example, the emergency surgery and the obstruction at presentation are factors that can influence non-surgical complications after operation, and on the other hand, the anemia, the diabetes mellitus, and the rectal cancer surgery per se are may influence surgical complications after surgery, mainly septic complications. And we also know that there are several factors that can predict the postoperative complication and mortality in this group of patients. For example, the ASA score, the combined surgery, the anemia and hypoalbuminemia are several factors that influence 30-day postoperative complications. And of course, there are several other parameters that the ASA score, the stage of the disease, and all these factors that affect 30 days postoperative morbidity that can impact the 1 year mortality in these patients. So knowing that, because these factors are often seen in the elderly, even nowadays, several elderly patients are often undertreated, and particularly patients who otherwise are fit for surgery. And this has to do with very bad results, as you can see here, because if you apply surgery alone or radiotherapy alone in these patients, the results could be very, very bad. Otherwise, if you apply combined surgery, you have better results. Laparoscopy is very beneficial in this group of patients, with exclusion of operation duration, which will be, of course, longer in several times. And of course, there are patients that cannot tolerate long-lasting operations, of course. However, all the other parameters, such as blood loss, cardiopulmonary complications, and morbidity, total morbidity, is quite less than in laparoscopy group than the OP group, and so laparoscopy is very beneficial for this group of patients. And of course, overall survival and survival indexes are very comparable between the two approaches. And of course, the literature supports the use of laparoscopy in this group of patients. And of course, as you can see here, the mortality rates are almost identical between the group of patients over 80 and the group of patients below 60 years of age. And all these parameters and all these factors, of course, lose their significance in extreme ages, just because the life expectancy is already too short in this group of patients, very old patients. Quality of life is the main issue when you perform colorectal surgery in elderly patients, and sometimes it's getting more important than the oncological outcome itself. And this is especially true for old women, because old women may experience high incidence of lower anterior resection syndrome, and mainly problems with bowel movements and fecal incontinence, and they exhibit behavioral problems, mainly depression, several times. And one has to know this and seek for alternatives, such as not to close an ileostomy or perform an APR from the beginning. Resection of primary tumor, if possible, of course, if feasible, of course, should be the primary endpoint in this group of patients, and the age per se will be not be an obstacle to perform the soil operation. But of course, because there are several problems and comorbidities in this group of patients, medical optimization is needed to proceed and to gain good results after the operation. So, in conclusion, the colorectal cancer is basically treated in the same manner as in the case of young patients. And finally, I think Professor Tekis will agree with that. The frail patients, the frail old patients, are very good candidates for watch and wait protocols. The results, as we can see here, is very good, very promising. And indeed, there are several patients, old patients with problems that make them poor candidates for surgery, that even though if they have not complete response from their cancer after radiotherapy, they will die with, but not from their cancer. Thank you very much.
Thank you, Dr. Athanasakis, for your nice lecture. Is there any question from the audience? Is there any point, Dr. Athanasakis, to measure the frailty of the patients and maybe adjust our... to use one of those measures of frailty of patients and then adjust our treatments?
Yes, I show there several scores, such as CR Possum score, ASA score, Apache score.
But is it useful in the end?
Yes, I think it's useful. In our department, we use the CR Possum score, and it is beneficial, yes, of course.
Any other comments? Okay. Professor Xinos? No comments.